Good afternoon, everybody, and welcome to this ESSO webinar on organ preservation in rectal cancer. We're going to discuss clinical challenges and new multidisciplinary solutions. My name is Gaia Spolverato from the Department of Surgery at the University of Padua, and it's a great pleasure for me to moderate today's session together with Professor Beetz from Maastricht. Organ preservation has become one of the most debated and clinical relevant topics on rectal cancer treatment. The possibility of avoiding radical surgery while maintaining oncological safety raise an important question around patient selection, response assessment, timing, and long-term surveillance. This decision can only be addressed through a truly multidisciplinary approach. Today's webinar is designed as a case-based discussion, bringing together surgical and radiation oncologists from Padua and Maastricht. Through real clinical scenarios, we will explore near complete response, watch and wait strategies, local excision, and the management of tumor regrowth, highlighting both opportunity and the limitations. The format will be interactive with short, focused presentation followed by a final discussion and a Q&A session. I encourage all the participants to actively engage and share questions or comments during the discussion. Before we start, I would like to know that all the speakers have declared no conflict of interest related to today's topic. So with that, I'm pleased to hand over to Professor Beetz, who will give us an overview of ESSO, and then to Ilaria Govoni, who will start with the first case. Thank you all and enjoy the webinar.
Well, thank you, Gaia. So you've seen the promotional video. Again, this is an overview of what we do. We do many things with ESSO. So it benefits to join ESSO if you are a surgical oncologist or if you are affiliated for all these reasons. One of which is also the European Journal of Surgical Oncology with a fairly good impact factor. And the other thing is that in cooperation with the UEMS, we provide the examination in surgical oncology for the European Board of Surgery qualification. And if you would like to do that, we can really promote this course on the basics of oncology for surgeons. We have also a lot of other courses that you can find on internet, and our yearly meeting. I all invite you to come to Madrid in November this year to join us there. With this, I would like to hand over the microphone to Ilaria Govoni, who will start presenting the clinical cases.
We would like to ask you if you can share the slide and share the first slide of the clinical case.
Are you seeing?
We just see the first slide.
Okay.
And not in presenter view.
Are you seeing the first case now?
We are not seeing anything now.
Then we stop sharing and share again.
Here we go.
Good afternoon, everyone. We start with the first case is a 75-year-old female with no significant comorbidities. And she presents in June 2025 with a 3-4 week history of rectal bleeding. On digital examination, rectal examination, an heart mass was palpated about approximately 1 centimeter from the anal verge. So you can skip to the second slide. Colonoscopy revealed a 3 centimeter polypoid lesion located at the anorectal anal verge. And the histopathological examination confirmed a moderately differentiated adenocarcinoma, MMRI proficient. The CT scan of the thorax and the abdomen show no evidence of distant metastasis. And for the pelvic MRI, I invite the Professor Beetz to review the images.
Thank you, Ilaria. So these are pelvic MR images. So you see this from the lateral side, and then this is transversal, and this is...
Regina, sorry, we cannot see the slides.
Oké, dan niet meer in de presenter mode, maar gewoon, ja. Like that, you see the slide?
Yes, we do.
Yeah, okay, how it so. So you see this lateral pelvic MRI from the lateral side. This is the axial, transversal. This is coronal. If we're dealing with a low rectal cancer, we should always make a plane which is exactly coronal and parallel to the anal canal. And then you will see the anal sphincter, the internal sphincter and the external sphincter and the levator. This is a protocol that is used with endoluminal gel. We will publish the updated guidelines on MR protocol. And in fact, what is being recommended is not to use gel, because gel would maybe be good to see the location of the tumor, but the disadvantage of the gel is that you completely compress the mesorectum, and someone who has not a lot of mesorectal fat, then it's very difficult to see the lymph nodes. So what we see here is a distal rectal cancer, semicircular like that. It's definitely going through the bowel wall, because bowel wall should be hypointense, should be dark, and you don't see that here. It appeared to have a node in the mesorectum. It's big, so we can still see that. Here you see on the coronal, and it looks as if the tumor is also invading the anal sphincter muscle. So on the right side here, of course, this is just a screenshot, but if you scroll through the images, it becomes clear that the tumor is invading the pelvic floor on the right side. So T3CD N1, no EMVI, mesorectal fascia involvement, and M0, as we already know.
Oh, thank you so much. So following the discussion at the MDT, the patient underwent a long course neoadjuvant radiotherapy, and 8 weeks later, the completion of neoadjuvant treatment, a digital rectal examination revealed no palpable mass, and the sigmoidoscopy showed a small ulcer covered with fibrin, consistent with a near complete endoscopic response. And 4 weeks later, another sigmoidoscopy confirmed a near complete response. So again, for the MRI images of the resedation, I invite Professor Beats.
Yeah. Yes. So the MRI shows a very good response. You don't see that gray mass-like tumor anymore. It's now fibrosis. I didn't show the diffusion, but the diffusion will have no signal. Diffusion is a sort of a functional imaging. If there is a high signal, there is an incomplete response. But this looks like a very, very good response.
Also, the CT didn't show any distal metastasis. So again, after the MDT discussion, the patient underwent a local excision that was performed in November, and histopathological analysis revealed a residual photo of adenocarcinoma, PT2. So, and the resection margin were negative. Based on these findings, the completion abdominal perineal resection was recommended and performed, with no residual tumor identified in the surgical specimen.
Okay. I'm taking over here. Well, there's lots of food for discussion here. So should you do a local excision? And if you then find a YPT2, should you do a completion surgery or not? So, but now we're going to address the near complete response entity, and both me and Regina, we're going to discuss the role of digital rectal examination, but especially endoscopy and MRI in assessing near complete response. So to start off with, where does the terminology near complete response come from? It comes from the fact that several years ago, when we started doing watch and wait, we were doing watch and wait for patients that had typical complete response, but everything else we were doing TME on. So all these patients that are shown here, they are not typical complete responders, but at the histology of the resection specimen, there was no tumor there. So that's where we started thinking, what's going on here? So we reasoned that maybe the neoadjuvant therapy has already killed the tumor, but the bowel wall has not healed. And what you can see here, what if you started waiting longer and use the test of time? Maybe it heals. And we have seen that it often heals, or it progresses to a tumor, and then you know what to do. So we were doing this with patients that had a very good response, but other surgeons were looking at it differently, and we did a systematic review on what do you consider a near complete response. So we looked at the literature, and 23 studies noticed a very good but not a typical complete response, but everyone understands something else under it. So on digital rectal examination, for us, it should be very good, except a minor irregularity or a smooth induration. But there were some surgeons who said, well, a very good response occurs when you have more than 50 degrees of tumor size. On endoscopy, for us, it needed to be a small flat ulcer, but other surgeons were saying, well, if you have a small residual tumor, that is also a near complete response. The same with MRI. There are lots of different definitions. So then we realized actually what a near complete response is something in between residual tumor and a complete clinical response. So it's a continuum, and you can consider in this continuum on the right side patients with a very good response who have a high likelihood of becoming a complete response. And on this side, you can have patients with probably residual small foci of tumor. Here you can see, I can tell this is a residual tumor, but some surgeons are calling this also near complete response, and there is something in the middle. So we have some problem with the definition of near complete response. Hoe ga ik verder? Nee. If you have a real good near complete response, what we are doing, so we set together 15 experts worldwide, and we all agreed that when you see a perfect endoscopic response and a minor thing on MRI that is not looking good, a small area of diffusion or a little gray signal, that is okay. We all agreed, let's call this near complete response. Or if you normal MRI and you have an abnormal but a good looking endoscopy, let's call this a near complete response too. But on everything else, we disagreed. Some people call it near complete, some people call it residual tumor, as we do. And this matters because if you look at the results in the literature on the left side, these are our patients. So we call near complete response something that is looking very good. We don't see residual tumor, but the bowel wall has not healed. Then the results of organ preservation are fairly good. So you have a little more regrowths, but not a lot. The curve on the middle is from the big international registry. But here patients are included after the second or the third. So there is bias here. So this says that the results of organ preservation are the same, but this does not include all patients. Then you better look at prospective cohort series like the one on the right. That's the OPRA study from the US, where they divide into clinical complete response, near complete response, and incomplete response. And if you take all that, and they were more liberal in naming near complete response, you do see that they have a lot more regrowth. So the chances of residual tumor are a lot higher. Here are some examples what they used for radiological criteria, and I'm gonna let Regina.
So it is obvious that the only very important sequences on MRI is in fact one, and that's called T2 weighted images, and you can recognize that because the bladder, the urine is white. So that and nothing else, no fat suppression, because it only gives confusing images. So these are the anatomical images, and incomplete response is tumor is gray. So that's very simple. Near complete response is going to be a very difficult gray area, because you may see still a gray residual tumor a little bit, or fibrosis. So that depends on how you look into a near complete response, which part of the spectrum. And on the restaging, okay, this is the baseline of a tumor, but on the restaging, I should point at this, you see either fibrosis with small gray spots. So mainly fibrosis, but the complete response is very clear. It's always fibrosis. Then if you look at the diffusion images, that is this one. So in the upper row, it is the primary. In the restaging is the lower row. And you can see that in the complete response, the typical clinical complete response, you see that there is no high signal of the diffusion. And the signal should be very bright, because this is normal physiological signal of the bowel wall. So only if you see very bright signal like this one, that is that we tend to say, okay, this is more confident that it's a residual disease. Now you can see that in the near complete response, it's not so very clear, that signal. And now I have to say that this is a very good diffusion image. The best diffusion image is if you do not have the endoluminal gel, because you're looking at white spots in the wall, and you need to have the contrast of the dark bowel wall and the dark surrounding. Now, the OPERA trial also defined a near complete response after TMT as partial regression of an initially visible node, and this node should still be large, so more than 5 millimeter in short axis diameter. And the incomplete response, you should also include the enlarged lymph nodes. So either a residual tumor or enlarged lymph nodes. In the complete responding part, you see an N0, so no node, but sometimes you see very small little nodes, and so do not always consider that as node positive, because then you would overstage.
Okay, thank you, Regina. So for patients with a very good near complete response, it's worth waiting, because many progress to a complete response. But for the small remnants like these here, which you can call near complete response too, we tend to call them residual tumor. Waiting further does not make a lot of sense. You need to make a plan. You do a TME or additional local treatment, which is what we're gonna address next. Then there is the intermediate category. That's either, well, there is something there, as you can see. Extending the observation period like they do in the Star Trek could be useful to see which way it goes. But I think you should be ready to make a plan for further local treatment or do a TME. So in conclusion, the near complete response thing is a somewhat inherently inaccurate category. It's a spectrum of diseases, and the use of the category depends on whether it's a high or low tumor. patient and doctor preference and what you want to do. If you always do a local excision, then it's easy for you to call a near complete response something with residual tumor. We tend to stick to the very good response. And the main thing is, if you see something like near complete response, there are further options for organ preservation. And I think that's what we're going to discuss next. We'll stop sharing and we'll let Ricardo Bao share.
We can see it.
Okay.
Right. Can you see it in presentation view?
Yes.
You do. Okay.
Well,
Okay. Thank you, Professor Beets, and thank you for this great topic to discuss about. And we know that traditionally patients who do not achieve a complete response are, in this case, the TME and the rectal resection is still the standard for this patient. But with the wide extension and diffusion of organ preservation techniques, we are trying to see if there are any indication for organ preservation in your complete response. And actually, if we look for the flowchart in the latest NCCN guidelines, only patients with a complete response are available for organ preservation with watch and wait. And transabdominal resection is still the standard for patients who do not achieve a complete response. But as we saw in the clinical case, there would be some potential space for local excision in the treatment of near complete response. And this is data from a French phase 3 randomized controlled trial, the Rectal study, that randomized patients with good clinical response to receive local excision or TME after neoadjuvant treatment. And in case of high-risk histopathological risk features, these patients were recommended to receive a TME, anyway, a compression surgery. And finally, in the trial, 73 patients were randomized to receive local excision, and almost half of them actually had an indication for a compression surgery. And the findings of the trial was that the survival at the long-term analysis was substantially comparable between local excision and TME. And the conclusion of the study of the authors was that local excision actually can be used for selected cases of good clinical response after neoadjuvant treatment. This is our experience from the Italian study for rectal sparing approaches. In our, this is the study protocol, and for patients with near complete response, local excision was recommended as treatment, and similarly to the Rectal study, the compression surgery was recommended in case of high-risk histopathological features. And the main advantage of the local excision approach is that we can have actually histopathological proof of the tumor response to the neoadjuvant treatment. And we can see in our data that among 70 patients with a near complete response, exactly half of them actually have a pathological complete response. However, 1/3 of them actually still have tumor residuals. So local excision in this patient with near complete response allows us confirmation of the tumor stage and a more accurate diagnosis of response. This is our updated data from the Italian registry, and substantially among 92 patients, we can confirm that approximately 1/3 of patients actually required a compression surgery for high-risk features, and the outcomes of this patient are pretty good. We see only 7% of local recurrence and 3% of distant recurrence, with excellent results in terms of survival. So I wish that you don't have concerning about local excision for near complete response. So we will discuss about briefly about watch and wait for this patient. Once again, this is the OPERA trial already mentioned by Professor Beetz, and we know that in the OPERA trial, patients were with near complete response were actually following a watch and wait program also. And we can see pretty clear in secondary analysis later published that approximately 40% of patients after total neoadjuvant therapy actually have a near complete response, and most of them were treated with watch and wait, and half of them, more than half of them, actually have a local regrowth. And this is really highlighted in this risk in the risk curve, that you can see that the rate of local regrowth for patients with near complete response is more than twice than complete clinical response. Of course, this turn out in impair survival, in particular for disease-free survival and distant metastasis-free survival. So, and actually, in all the cases, in most of the cases we saw, and we know that patient with local regrowth, this is quite still debated, but there's some evidence about, and patient with local regrowth after watch and wait actually have a higher risk of distant metastasis, and this was reported, for example, by this study by the Memorial Sloan Kettering, and later by the International Watch and Wait database, where they found that patients actually with local regrowth have a 5 times higher risk of distant metastasis, and local regrowth is actually an independent risk factor for distant metastasis. And in the latest study, we can see also that patients with local regrowth and treated with salvage surgery actually have a higher distant metastasis when compared to total mesorectal excision and local excision for near complete response. So when we look to the European guidelines, actually for near complete response, local excision is one of the recommended surgical option. And to be honest, if we look in details the American guidelines, you can see that there's a mention about near complete response and the option of using a local excision approach, pursuing a organ sparing approach. So in conclusion, near complete response is still a challenge for rectal surgeons, and even if TME is oncologically safe, but in most of the cases we saw that it can be an overtreatment for these patients, and organ preservation with near complete response is still debated, of course, but local excision have shown comparable oncological outcomes of TME, and instead of watch and wait that shown some concern, particularly in the rate of local regrowth and the distant metastasis.
Okay, thank you, Ricardo. If you can stop sharing, then we'll share and go on.
I think we're not sharing anymore.
No, I am.
Nee,
No.
nee, achter dit. Het zit achter jou.
We'll try. Share. And
Okay.
can you see the presentation now?
Yes.
Yes. Okay. So my name is Mike Berbe, and I'm a radiation oncologist in Maastricht.
Oh,
and
not yet. Sorry.
Not yet.
I think when you share, you need to choose, because there will be a few screen that you are opening. You have to choose a screen with the slides on. So when you press share, there you
Now,
go. Okay,
second
it
try.
works now.
Yes.
Yeah. Perfect. And if you go to full screen?
Yeah, then it will stop.
Yeah,
we can try.
We'll try.
Yeah, let's try.
Let's try.
There.
Okay, the first slide you can see, but the question is, will you see the second slide?
No, you're right.
Are you seeing the second slide?
No.
No. Stop share. Okay. Now you can see the second slide, I guess. So can we use radiotherapy to increase the complete response rate in case of a near complete response? Does it make sense to increase the radiation dose? Well, I think by now there's sufficient data to claim that the answer should be yes. The graph that you can see over here is a graph in which several patients cohorts are being combined. If you look at the upper line, those are data from patients that reached a near complete response in the pathology and a complete response in the pathology specimen. On the x-axis, you see the radiation dose. So what you can see that if you increase the dose, the chance of a complete or near complete response increases. And what you need to note that at 50 gray, and that's kind of the most commonly used dose for neoadjuvant chemoradiotherapy or in TNT, there's about a 20% complete response rate, and you really have to increase the dose a lot to go to more significant chances of complete response. So the dose should be a lot higher. And then the question is that doable? And it is, but you need to take in mind that you should increase the dose to a really small and selected volume, so only where it should be delivered, so to the tumor. The graph that you see here are lines that show isotoxic effects. So all the dots on the line, those patients had the same probability of a certain toxicity. What you can see here is that you irradiate a large volume, you reach the same toxicity with a relatively low radiation dose. If you really limit the volume, you can go up to much higher radiation doses. So if we want to increase the complete response rate of the tumor, we should deliver the radiation dose very selectively to the tumor. And I think by now there are several options to do that. You can do it either endoluminally using HCR brachytherapy or contact therapy with the papillon machine, or you can use the new kind of therapies in external beam radiotherapy like MR-Linac or ETOS machines that can provide daily online adaptive treatments. So those are all options to kind of more selectively deliver the dose to the tumor. But in this case, like if you want to increase the complete response rate of rectal tumors and you want to be really selectively, I think the most logical way to go is to provide an endoluminal boost, because if you irradiate from the inside, you can really selectively irradiate a small volume, opposed to irradiating from the outside, whether it's either photons or particles like protons, you will, per definition, be less selective. So if you want to go up to this very high radiation doses, I think going endoluminally kind of is the most logical way to go. And then if you look at the various endoluminal options, the most selective options are either contact therapy with the papillon machine or HCR brachytherapy with applicators that provide a similar dose profile as contact therapy. So this is a small picture of an afterloader. So I think most departments have an afterloader that contains a small iridium, a radioactive source on a cable, and that can be guided, the iridium source can be guided to the tumor through an applicator. And we've done some dose calculations to get an idea what's the actual delivered dose if you use contact therapy. So contact therapy has been around for years, and traditionally 3 fractions are being prescribed with 30 gray at the surface of the applicator. So this does not say much about the dose delivered to the tumor, but if you kind of recalculate the dose to the tumor, and we've done that based on endorectal ultrasound images, you see that depending on tumor thickness, you give an extra dose of 60 to over 200 gray. So with these extra doses, it's kind of likely that you will increase the complete response rate. And now I'll show some images of patients that we've treated with endoluminal therapy with an HCR applicator. So these are images of 3 consecutive fractions. So it's kind of remarkable how much change you see from week to week between the different fractions. So this is a tumor before start of treatment, this is after 1 fraction, and this is just before the 3rd fraction. And besides kind of assessing the tumor endoscopically during the endoluminal boost fractions, we also make and the rectal ultrasound images, and kind of these images show a similar view. So you can really see the tumor shrinking between the different fractions. But I think if you look at this specific scenario, you kind of need to be aware that most data on endoluminal radiation therapies for rectal cancer, they're from different scenarios. They're from the scenario that you decide upfront to give a boost. And I think for the future, we need to kind of think of what's the most logical way to go. Do we want to kind of offer a rectal boost to all patients, or only start to administer when patients have a near complete response? And I think there's a lot of research that still needs to be done. In the region, we're also working on that. So I think in the case of a near complete response, it's important to compare the effectiveness and the toxicity of the therapy compared to local excision. And if we are applying a radiation boost in the near complete response scenario, we kind of really need to know kind of what should be the volume that we irradiate. Is it only the macroscopic tumor, or is it likely that there's also microscopic tumor spread in the surrounding rectal wall? And that's something that we're now investigating in a trial called the DETECT trial, in which we kind of analyze pathological specimens. And my take-home message for today is that I think radiation boosting in a near complete response scenario really makes sense. But you really need to be aware that you should deliver a very high dose to a very selective volume, and the most logical way to go is then an endoluminal boost.
Okay. Well, thank you, Maaike. So we've heard about the options there are for a near complete response. We're now going to move to the next clinical case, and Ilaria can take over on the regrowth.
Okay, just for the people who are sending some questions, I would leave the discussion at the very end of the two cases, since some of the questions can relate it to both. So I'll have Ilaria going forward. Can we share the screen, please?
Yes. So this is the case.
Yeah. Hold on a second.
Are you seeing the slides?
No, we are sharing now. Can you can you see the slides, the clinical case too?
Yes.
Yeah.
Okay. Thank you.
Yeah. The second clinical case involved a 50-year-old female with no significant comorbidities. And she presented in October 2021 with 3-month history of rectal bleeding and tenesmus, altered bowel habits. And the digital rectal examination revealed no palpable mass. And they perform a colonoscopy in October, and they identify a 4-centimeter ulcerate rectal lesion. And the histopathological examination of this lesion confirm a well-differentiated adenocarcinoma. The CT scan didn't show any distant metastasis. And again, for the images of the MRI, I invite the Professor Rees to comment.
Okay. Yeah. Unmute. So it's a very simple image. I think the most illustrative, you see a tumor almost very high in the rectum, almost at the sigmoid takeoff. I mean, some part, the highest part is in the sigmoid almost, and the lower part in the high rectum. Again, the gel influences the height of the tumor, so it's not reliable anymore on the MRI because it pushes up the tumor. And also, this patient had not so much mesorectal fat, so it's very difficult to see the nodes. But the images, if you scroll through it, does not show any big nodes. And it is a tumor that is invading penetrating the bowel wall. So T3 and 0 no mesorectal fascia invasion.
Thank you so much. For this patient, following the MDT discussion, total neoadjuvant therapy strategy were choose. So after the end of the total neoadjuvant therapy with Xelox and following long course chemorad, digital rectal examination didn't show any palpable mass, and the sigmoidoscopy performed after 8 weeks and also after 4 weeks later show a complete response, so with a very flat scar, and also you can as you can see in the images. For the restage with the MRI, I invited Professor Bistan to comment the images.
Simple remark that you can hardly see the tumor anymore, and it appears to be in the at S1, S2 level, somewhere like that. But because there is only fibrosis, you do not see the beginning and the end of the field of the irradiated tumor. So this is almost, in fact, gone, the tumor.
Because of this restaging, the MDT meeting choose for this patient a watch and wait program, and the patient had a regular follow-up for 6 months until in January 2023, a sigmoidoscopy show at 10 centimeter from the anal verge a retractor scar with regular surface, as you can see in the images. And the biopsy were taken, and they show adenoma with low and high-grade dysplasia. No distant metastases were found, and the pelvic MRI didn't show any big pathological things. So following the MD discussion suggests for this patient a local excision or the TME, but our group decided to perform a local excision, and the pathological examination found low and high grade dysplasia with a negative margin. So the MDT decided to just follow up this patient, and the last follow up in January 2025 was without evidence of disease. No.
Basta. So we are going forth and discuss about surgery for regrowth. Okay, there we go.
So we know that among patients treated with watch and wait approach, the rate of local regrowth ranges between 20 and 30% of patients. So these are patients that in 1/3 of the patient we have to go through a salvage surgery. And this is our experience from Italian registry published data. We have a 27% of patients experience local regrowth, and most of them were treated with a salvage surgery, mainly with a TME. Most of them have a sphincter saving surgery, but to note, also one patient have a pelvic exenteration, and just a small percentage of them had local excision, and one of them required also further compression surgery. But we can see in this table that approximately 20% of patients still doesn't have any residual tumor at the histopathological analysis. However, all the patients have a curative surgery with 100% of R0 resection, and without any patient with nodal metastasis. So very early stage regrowth. And similarly, we can see this approach in this study by Professor Beets and the Dutch Watch and Wait Consortium, and among their patient with local regrowth, approximately 2/3 of patient had a TME, and 1/3 of patient had a local excision, and supporting this approach, we can see that total mesorectal excision is basically a safe approach, and in most of the case performed with a minimally invasive approach with a really low rate of conversion to open surgery, and in most of the cases have a curative resection, R0 resection. And the postoperative major complication is acceptable and around 10% rate. And once again, there's still a rate of patient that didn't have any tumor residual at the histopathological analysis. Regarding the survival, we have excellent 2-year survival, and the conclusion of this study was that substantially the vast majority of the patient with local regrowth can be managed with a salvage surgery. Once again, we talk about the OPERA trial. In the OPERA trial, we have I already told you that most of the patient with local regrowth had initially a near complete response. And when we look for the outcomes of this patient, we have with salvage TME a good control, local control of disease, but once again, we have an increased rate of distant metastasis in these patients. So as we saw in the clinical case, there will be some indication for local excision, and we can see this study from the group of Brazilian group from Sao Paulo that they treated all the patients that have histopathologically confirmed local regrowth, most of them with TME, and 1/3 of them with local excision. And when they compare the two treatments, they found a local control, similar local control, although they found an improved 3-year distant metastasis-free survival in the local excision group. And but it is important to show that patient with local excision in this study was performing patient with smaller tumor regrowth, with early stage at baseline at diagnosis, and with smaller pathological tumor size and early pathologic stage at the final histopathological analysis. And so the conclusion of the Brazilian group was that local excision should not be routinely offered to patients with local regrowth, but is an alternative to TME in a selected patient. And similarly, this study from Professor Beets showed us that local excision can be used in patients with local regrowth, even in early regrowth and later regrowth, and the rate of salvage surgery is about 20% of patients. With good control, local control in both cases, and with curative intent surgery in all patients requiring salvage surgery. So conclusion of the study was similar to the previous study. So local excision can be considered as an alternative to TME for suspected regrowth in selected patient to continue our organ preservation approach in these patients. Lately, this is our submitted work is substantially a work regarding delayed TME after organ sparing approach. You can see we collected 13 patients in the research registry that had actually a salvage TME for local regrowth. And we compare patient having a completion TME and a salvage TME by doing a propensity score matching to the patient having a standard treatment with the standard TME after neoadjuvant treatment in our institution, and we found no particular difference in terms of surgical outcomes in 30-day complication, anastomotic leak, and reintervention and mortality. And regarding the rate of recurrence, we found a similar rate of overall recurrence and distant recurrence between the treatment. So in conclusion, salvage surgery is required in approximately 1/3 of your patient during a watch and wait approach. But with an appropriate follow-up, most patient can be treated with curative intent with the salvage surgery, with TME that have shown to be technically safe and with acceptable postoperative complication. And salvage surgery show us very good data regarding the local control disease, but still some concerning about distant metastasis. And local excision, on the other hand, can be a good option in very early regrow and in very selected patients.
Okay, great. Thank you. So we have 6 minutes left and quite a lot of questions. So
I can start off with one that asks about if there's discordance between digital rectal examination, MRI, and sigmoidoscopy, which is the most important in labeling clinical response. And I have to say that it's quite clear that it's mostly endoscopy, helped by digital rectal examination and MRI, but we often go more on endoscopy.
So there is also a question for the radiation oncologist. What option of treatment you choose in a non-surgical setting with prior radiotherapy, re-irradiation with radiotherapy, or brachytherapy? What factors are you taking into consideration?
Sorry, could you mention the scenario again? When was the...
We are discussing about patient that had prior radiotherapy.
Yeah. It really kind of depends on the time interval and whether the patient had surgery. So if there has been no surgery and it's kind of the residual disease, I would go for brachytherapy and then the most selective treatment option. If it's like a status after a chemoradiotherapy and surgery, we usually go for re-chemoradiotherapy with a slightly lower radiation dose than in the first setting, then with a total dose of 30 gray, because we believe that administering 50 gray on this really large volume for the second time is too toxic.
Yeah, they also ask if we have data on risk of side effects comparison between local boost versus local excision. I don't really think that we have data to answer this question.
Hopefully the OPAX trial will provide those answers. And I think for future analysis, you really need to take in account which local boost option is being used, because I expect quite some differences in toxicity between the various options. For example, we know from cylinder brachytherapy that there is more toxicity than in KV contact therapy.
Regina, do you consider PET-CT anytime? We don't at all, but...
No, there is no indication for PET-CT, although there are papers that shows that PET-CT can, to a certain accuracy, also identify the response and residual disease. But the problem of PET-CT is, of course, the resolution. And the resolution not only of the PET part, but also of the CT, which is often without contrast. So this is not included in the guidelines as being recommended.
Okay, thank you. And to answer the question on the role of biology, I would say that there are a lot of studies going on. One of the most interesting is on the role of circulating DNA, but we still are not able to define priorly those patients who will respond and those patients who will have to undergo a TME. We also are working on a project on the role of AI and radiomics in defining, and I know that you are doing so as well, in defining and better define which patient will respond to chemoradiation and to better select those who have real complete response from those who have almost or a major clinical response. But again, we still don't have a clear question on this, a clear answer on this question. So there is one very last question on the possibility to see this webinar remotely. I think that the office can answer to this question if it's possible to send a registration.
I think they can be reviewed later on.
Yeah,
Okay.
all of the ESSO webinar, it will be published on our learning resources. So if you go on essoweb.org and then learning resources, you will find all our previous webinars, including this one, which will be uploaded in the next few days.
Great. So as we come to the end of this webinar, we'd like to briefly highlight a few key lessons learned from today's discussion. First of all, organ preservation in rectal cancer is not longer an experimental concept, but a real therapeutical option for selected patients. Second, the cases discussed today clearly show that clinical complete or near complete response is a dynamic process, not a single time point. Third, a multidisciplinary decision-making is essential, and it's better to do it even with people who come from different countries, who have different vision and different cases to share, because the success of organ preservation strategy depends on close collaboration between groups, as we are doing today. 4, wash and wait is an active strategy, not a passive one. It requires a strict surveillance protocol, patient compliance, and I underline patient compliance, and readiness to intervene promptly in case of regrowth, because all the data that we see in the literature come from third-level center, and we have to be very careful to generalize this data in different settings. And finally, this case reminds us that patient-centered care is the core of organ preservation, because balancing oncological safety with functional outcomes and quality of life is our guiding principle. I would like to sincerely thank you, all the speakers from Padua and Maastricht, for sharing their expertise and real-life experience, and of course the ESSO for providing this platform to exchange and education. Thank you all for your participation and engagement, and we look forward to continue this discussion in the future as educational activities. And of course, we see you all in Madrid.
Okay.
Bye.
Thank
Bye.
you.